Hello class. So a lot of students I get asked all about NSAIDs. Which NSAID do I use? Is it ibuprofen, naproxen, celecoxib, also called Celebrex, or others? Or do I not use any? Which medical conditions precludes me from using one versus another? If someone has heart disease versus kidney disease versus gastrointestinal issues. If they're already on a blood thinner such as aspirin. So this little flow chart, which again is messy, horrible handwriting, sorry, but at least it's the all-in-one slide. Start at the top, go through the different risk factors: cardiovascular risk, yes, no; GI risk, low, high; on aspirin, are they not on aspirin, and then take it from there.
All right, so today we're going to talk about NSAID selection as it pertains to cardiac risk and GI risk. So here we go. First, we have to be concerned about, of course, cardiovascular risk, right? That's a big problem. So let's say you have a young, healthy person that has low cardiovascular risk. Then what do? We then break it down into GI risk. If they have low, right, GI risk, then we can give actually any non-selective NSAID, with ibuprofen being the main one. So this is what we often give to our young and healthy folks that don't have any risk. What if they have high GI risk, right? Well, then we have a problem, since if you go down the cascade, right, membrane phospholipids become arachidonic acid via phospholipase A2, and then that in the GI system will go down the COX-1 pathway to make prostaglandin, actually prostaglandin E2, and E2 results in increased mucus and increased bicarbonate to help with buffering. And if we knock that out, and our body does not make prostaglandin E2 anymore, we risk bleeding. So this is where Celebrex comes into play, right? Celecoxib is our preferred drug. Some people go so far in terms of maybe, plus minus adding on a proton pump inhibitor even. All right, now, what if we have someone with high cardiovascular risk? Well, then we do the same thing, right? We first go to GI risk, and if they are low, right, GI risk, what do we give? And there's been some neat studies out there that showed actually naproxen seemed to be the best in terms of lowest risk of cardiac events. So that's our go-to in that situation. Now, some savvy medical students are real fast to pick up, wait a minute, their cardiovascular risk, right, high risk, they're probably on aspirin, right? So what if they are on aspirin? So if we review that same pathway, right, phospholipids become arachidonic acid and go down the COX pathway. COX-1 in the cardiovascular system produces thromboxane A2, which results in platelet aggregation. However, COX-2 in the cardiovascular system produces prostaglandin I2, or prostacyclin, which inhibits platelets. Right? Naproxen is going to inhibit COX-1. Aspirin is going to inhibit COX-1. That's why aspirin is very good in terms of inhibiting platelet aggregation via that pathway. Celecoxib, however, or Celebrex, is going to inhibit COX-2 and achieve a little balance in the cardiovascular system. So if they are on aspirin, which inhibits COX-1, we can give them a low dose Celebrex or Celecoxib in this situation. Now, I'm actually going to update this here. Should get rid of that and do that, since this last arrow signifies if they are cardiovascular high risk and GI high risk. We're running out of space here. So what happens if they have high cardiovascular risk and high GI risk? We have a problem, right? So what do we give? Well, actually, the answer is we probably shouldn't give anything. Although some, if you really have to give something, naproxen plus a proton pump inhibitor. We're running out of room here. And then to round this out, if they are high cardiovascular risk, high GI risk, and they're on aspirin, then, yep, you guessed it, we should not give anything, right? Because they are the highest risk. But in a pinch, if a physician really wants to give something in this situation, all we're left here is low dose Celecoxib, sorry, can't fit that in there, and a proton pump inhibitor. That's your last chance here, but really the answer should be none. By the way, what is low dose? Well, in the Celecoxib world, that is 200 milligrams a day. And by the way, Celebrex or Celecoxib is COX-2 selective. So it mostly inhibits COX-2. But there was one out there called Vioxx a number of years ago, and that was actually COX-2 specific. Really running out of space here. And that was a problem. If it's 100% COX-2 specific, you're going to absolutely inhibit COX-2 only, so you're not going to make any prostacyclin to inhibit platelets. All you have left is COX-1, which in the cardiovascular system is thromboxane A2, which results in platelet aggregation, and there's all your increase in cardiovascular events, which is why it was pulled from the market. All right, hope that helped.